name is Sierra Arbaugh, and I am a freshman nursing major at West Virginia University. I have been participating in biomedical research with Dr. Matt Akers in the NICU at WVU Medicine Children's Hospital. Our research focuses on the effect of a Silverman-Anderson respiratory severity score-based CPAP weaning algorithm on newborn CPAP duration. Respiratory distress is common in newborns and can be demonstrated by symptoms such as tachypnea, nasal flaring, grunting, and chest retractions. Respiratory distress can stem from a number of causes, including disrupted birth transition, infections, or problems with cardiac or pulmonary development. Management can vary depending on cause, but it often requires provided respiratory support. CPAP is a respiratory support method that can treat respiratory distress. While beneficial, complications of CPAP utilization include nasal trauma and pneumothorax and longer hospitalizations. Prior to our study, we observed many newborns on low CPAP support with minimal respiratory distress and thought that the risks of CPAP therapy might outweigh any ongoing benefits at this point of care. Because of this, we implemented an algorithm to guide weaning of CPAP by nurses and respiratory therapists. Before this, doctors or neonatal nurse practitioners directed CPAP weaning, and high NICU patient volume or acuity resulted in delays weaning CPAP. Figure 1 shows a timeline for our study. A retrospective cohort study of the electronic medical records was performed. The study followed a practice change in the NICU that implemented an algorithm to guide weaning and discontinuation of CPAP respiratory support. A pre-algorithm period and post-algorithm period were analyzed. Following data analysis, a quality control audit was performed to determine if the algorithm was being used correctly. The algorithm, shown in Figure 2, was based on the Silverman-Anderson score, which is used to assess respiratory distress in the neonate. Scores are assigned to 5 exam areas, with higher scores meaning worse respiratory distress. Neonates born at 34 weeks gestational age or beyond with need for CPAP were included in the study. However, neonates were excluded if they had congenital heart disease, airway anomalies, neuromuscular disease, or chromosomal disorders. Medical records were reviewed for inclusion criteria and relevant characteristics. Patient characteristics, which are shown in Table 1, were similar between the two cohorts. Outcome data are presented in Figure 3. Analysis of the two cohorts found no significant differences in the primary or secondary outcomes. CPAP duration was not different between the two groups. Because practice changes, though intended to produce a desirable outcome, can also have negative effects, we examined for differences in several balancing measures, which are presented in Figure 4. While no significant differences were observed between the two cohorts, there was a trend towards decreased use of alternative respiratory support in the post-algorithm cohort. We were surprised to see no differences in the outcome data, as the project was generally viewed in a positive light in the NICU, as staff believed it was working well. However, given no difference in outcomes between the cohorts, we assessed for algorithm adherence. The results of this quality control audit, which are shown in Figure 5, revealed that the algorithm was only followed correctly in 32% of cases. An 11-hour difference in CPAP duration was discovered between correct and incorrect algorithm usage. After analysis of the quality control audit, a quality initiative was implemented that included daily team huddles, staff re-education, and identification of project champions in the nursing and respiratory therapy staff on day and night shift to help reinforce project goals. In the 2 months following implementation of the quality initiative, adherence to the algorithm improved from 32% to 69% to 93%. This is shown in Figure 6. In conclusion, an algorithm to guide CPAP weaning and discontinuation was successfully developed and implemented in our NICU. In the primary study period, algorithm adherence was poor. This may have led to detecting no differences in the outcomes between the cohorts. Following introduction of the quality initiative, algorithm adherence was improved and may result in better outcomes. In the future, we will be continuing elements of the quality initiative to sustain algorithm adherence. We will also be performing a secondary data analysis of outcomes following the quality initiative. This will include the overall outcomes as well as subcategories for adherence versus non-adherence and term versus late preterm infants. We may also study whether a scoring system, like the one used here, can help identify which neonates actually need CPAP from birth. Thank you.